Welcome to the 2023 KHAM webinar series. I'm Julie Haleska, the KHAM webinar chair and vice president of Health Recon Connect. And I'm excited to introduce Matt Barlup. Matt has been in the healthcare IT industry for 20 years, helping bring valuable technology to health systems to deliver efficiency gains for staff and improve patient experience throughout the care continuum. And I'm also excited to introduce Brian Haney. And Brian has been in the reimbursement patient access space for the last 15 years, helping patients and providers navigate insurance and find the financial support programs. And I am so excited for them to present today. When I saw this technology at HFMA that was in May, I believe, Lance, who was going to do the demo for us today, couldn't make it. So Brian and Matt are joining in and going to present for us today. But I was blown away by the technology. And anyway, take it away, Brian and Matt.
Very good. So thank you all for the time today. So what I hope to do is just give you a little bit of background about Infinitus, who we are, what's the problem we solve, how do we solve it, and then Julie, thank you for the tease of the demo that we'll certainly show as well, because I think ultimately to experience this technology in action, I think is going to be eye-opening for many folks on the call. So as way of sort of background as an organization, Infinitus was founded in 2019. The co-founders came from Google. They were working with some digital assistant technology that could automate phone calls. And the first use cases they were looking at was to automate phone calls to organizations like a restaurant or a spa to make a reservation. The wife of one of the co-founders works for a large pharmaceutical company, works in their patient access program. She heard the demo and said, that's interesting technology, but you ought to apply that to healthcare. And the Google guys said, well, what do you mean? So she went on to describe all of the manual phone calls that her and her team have to make to figure out sort of out-of-pocket costs and coverage for patients. And so that became the direction of travel for Infinitus in 2019. And so from a business problem perspective, what we're focused on are all of the repetitive phone calls and faxes that happen in healthcare between payers and pharmacies and patients, providers, as well as the pharmaceutical or med tech devices. There's lots of interaction between each of these entities to do things to check a status of a basic something, to exchange data, to initiate a process. Lots of administrative back and forth that because there aren't data standards, because there's lacking data interoperability in many cases, these phone calls and these faxes still exist. And so the problem we're trying to solve is if you could reduce these calls to zero, wouldn't that free time for folks to have more time for patients, allow folks, the reason they got into healthcare was the care part of healthcare, not administration. And so that is what we've been focused on since 2019 as a business. And we began our first automation support around this sort of back office workflow, these back office processes that are related to revenue cycle and patient financial. So if you think about in your teams or you yourselves have lots of folks who spend time with back office workflows that were phone-based. So whether they have to call to check benefits and eligibility, to check on provider referrals, to check on the status of a prior auth, to check on the status of a claim, lots of minutes are spent, billions of minutes we believe are spent in healthcare every year, just following up on these basic processes. And now the problem is even worse because the staffing crisis has made it almost impossible to hire enough folks to make these calls. It puts more burden on nurses and pharmacists and doctors to have to do more administrative work than ever before, which reduces the amount of time they have for patients, which with patients who don't have as much support, leads to poor sort of outcomes. And so the whole cycle is a vicious one that we're just trying to tackle from a new angle. So the solutions that we're going after, or the operations that we support across healthcare businesses, are squarely in that revenue cycle and that patient financial assistant. But unlike other technologies, there's a bunch of technologies called RPA or robotic process automation. What those technologies do is they go to a website, they go to a portal, they'll pull or scrape some information, take that information, put it into a system, and they're all about sort of desktop automation. And there's certainly a place for that. But because of the advancements that have happened with large language models and natural language processing and machine learning and AI, there's now the ability for an interactive voice assistant to perform these tasks on behalf of humans. So if you think about a phone call to a patient, or excuse me, to a payer, what happens today is your team, somebody has to call, right? So they navigate through a phone system for a particular plan. They're on hold, right? They're put on hold for 5 minutes, or it could be an hour and 5 minutes in January, given re-verification. The payer agent comes on the line, and you have to credential yourself. Hi, I'm calling on behalf of this provider to check benefits for this patient, this member ID. Here are the codes and the information I'm looking to capture. You get to answer or ask the questions you're looking for. And then you might be able to ask about a second patient, but more than likely you're gonna have to hang up, and your team makes that same phone call, maybe to the same plan or to the next insurer, to ask that process over and over again. And more than half of that time is spent on hold. The way our technology is set up is, instead of our customers having to make that phone call, what our customers do is send us those call requests via technology. We can sort of talk about sort of the how, and then we've got a digital assistant that does the rest. So our digital assistant calls the payer, it navigates through that payer's phone system, sits on hold, and then when the payer agent comes on the line, our digital assistant credentials herself in. Her name's Eva. You'll get to meet her here in a second. And then we ask the questions that our customers want asked, turn that conversation into text, and then send all those answers, all the data that the customer was looking for from a phone call. They get all of that back into their systems without them having to make the phone call itself. And again, we've been making these phone calls now since 2020, and just eclipsed our millionth phone call in the month of January. So today, that technology, we work with surgical centers, we work with hospital and health systems, we work with the payers themselves, pharmacies, pharmaceutical, life science companies, labs and diagnostics. Everyone has these types of calls that they have to make, whether their focus is on prior auth support or claim support or benefits and eligibility or some combination. And that's where we've provided a lot of the data, a lot of the information that we can provide. So I think the best way to kind of understand what this technology is to experience an actual phone call. So I'm going to play for you, and I'm going to just switch screens here. Play for you an actual phone call between our digital assistant and a pharmacy benefit company. And it's about a 3-minute demo, but I think this will give you a good flavor for how this technology works.
Thank you so much for calling Humana. My name is George. May I have your name, please?
Hello, this is Eva, calling on behalf of member patient to verify their pharmacy benefits. This call is being monitored and recorded for quality and training purposes.
Perfect. And can you tell me what is the member date of birth?
Patient's date of birth is
Great. I do have the account in front of me. And tell me, what information do you require for this policy?
I would like to verify pharmacy benefits as well as some information about the policy.
Can you tell me how many milligrams it is for?
The dosage is 5 milligrams for a 30-day supply of 60 tablets.
It is covered under the member's policy. And the classification, it is number 3.
Thanks. What is the policy effective date?
January the 1st of 2015.
Is the preferred drug?
It is preferred brand.
Is prior authorization required?
No, there is no need.
What is the copay or coinsurance for the 30-day supply of?
From a standard pharmacy, it will be $47 copay.
What is the copay or coinsurance for the 90-day supply of?
It will be a copay of $125.
Is there a preferred specialty pharmacy from where the drug can be obtained?
Yes, he can get it from Walmart Pharmacy, Costco, or Kroger Pharmacy.
Is there a preferred mail order pharmacy?
It will be with Humana Pharmacy mail order.
Can I have the phone number for the mail order pharmacy?
The phone number is 800-379-0092.
Is this a Medicare Part D plan?
Yes, it is.
What is the individual deductible for this plan and how much has been met?
It is $445, and so far the member has not paid any amount yet.
How much has been accumulated toward the initial coverage limit?
$68.96.
How much has been accumulated toward the true out-of-pocket?
$68.96.
Can I have a reference number, please?
The reference number will be
One last question. How was your experience today chatting with me?
it was a great experience.
And so that's an example of a call that we make thousands of times a day. Again, as I mentioned earlier, we've been calling the insurance companies since 2020. We started calling on the major medical side. Whoops, close that up. On the major medical side, we can call on the pharmacy side. We can call both, where as necessary. But again, one of the real benefits is we'll ask whatever questions our customers want asked, but we do so in the same sort of sequential manner. So what that does is that creates a standardized call on the payer side, and why the payers like speaking to Eva, and why some of the payers actually have dedicated teams that just speak to Eva, is that it takes the payers less time to answer questions from Eva than to answer questions from humans. If you think about sort of if your offices were to call about a particular medication and another office would call about a particular medication, there might be, and probably are, variability in terms of what the questions are asking. They might forget to ask questions, but with Eva, the questions are asked in the same manner and consistently over time. So it creates a very fast and efficient call for them. And again, as we mentioned, we've just completed our 1,000th call this month. We talked to over 160 of the payers there. And as you would expect, if you expect sort of a digital assistant or a machine to provide a service, it should be faster, it should cost less, and it should provide higher data quality. And our customers have documented that it certainly does provide a higher quality of data, because what we're able to do in that conversation, as I mentioned earlier, is turn that conversation into data that we then send back to our customers via API to go back into their systems of record so they get all the data without having to make the call. But why don't I stop here and open it up for questions based on what you heard, and we can go from there.
Anybody have any questions for Brian? I was wondering what the efficiency is with like inpatient access, if you know what the savings time-wise is, and then monetarily.
Well, so I think the savings time-wise is the ability to, it doesn't take a nurse or somebody in the back office to make that call. So the cost of the actual call is a less expensive call. What we're able to do is when we call and we get information about a patient's out of pocket, and we know there's a patient access program tied to the medication, we can actually then also take that same data and then auto enroll that patient into a patient access program. So in some ways, we can eliminate a step in the process in order for that patient to then get on a financial assistance program as part of that benefit verification, versus today's process is likely you do a benefit verification, you determine the patient has an out-of-pocket cost, you might do some sort of financial counseling discussion with that patient. You then have to find the enrollment form for that patient assistance program. You then complete that enrollment form, send it into the same patient access program. That patient access program then makes another call to check on benefits. And so we can help eliminate or reduce the amount of just calls and processes that are in the ecosystem as a whole.
There's a great question in the chat. It says, is there a scenario where the payer refuses to talk to Eva?
Yep, that does happen. So, and we've got a process where we've got a team of QA and benefit specialists who are monitoring everything that goes on with Eva. If a payer agent ever says, you know what, I don't want to speak to a digital assistant, I'd rather speak to a human, what our customers typically request from us is we drop in a benefit verification specialist, a human, to then complete and finish that call. But that happens less and less. And as the payers have seen the benefits of actually speaking with Eva, they're seeing great benefits in doing that. But we always have that human in the loop process that's there to sort of monitor, not only making sure we can provide that support where that's requested, but it's also there from a QA perspective to make sure that if Eva has heard 20% as a co-insurance, for example, is 20% what has been translated and put into the data fields for you, and just making sure that the data is accurate, because this is patient data. There's medications, there's treatments, there's other things that are dependent on this data and depend on the accuracy of the data. So it absolutely, we have processes with humans to be able to support all of that.
Anyone else? Let's see if there's anyone. Okay, Nino says thank you. Anyone else have any questions for Brian? What do you think of I just wonder with the group, what they think of an AI tool, how comfortable the hospitals are with that.
Julie thinks that's a good question. This is Terry. Yeah, and I could not get on the thing, so I'm watching this from my phone. So completely crazy here,
No
right?
worries.
Yeah. Anyway, I do use AI already in robotic RPA to do claim status, et cetera, through one of our other tools. Actually, I use 2 different vendors now, but this is absolutely new to me, this voice assistant. I'm super impressed. So I'm going to just answer your question with another question. And so in regards, what's the, is there a limit to how many payers are on here? Is there, only certain hours that the voice assistant can work? Because, AI 24/7, right?
Yeah, correct. Yeah. So the only limitations on when the AI can work, because if we're replicating a phone call, there's a dependency on the hours of operations of that call center on the payer side, right? So we can call on Saturdays because they're available on Saturdays, but it's also dependent on the capacity on the payer side as well. So for that particular use case, because it's call based and because it's tied to a call center that has finite hours, that's sort of when it can make those calls. But it can make those calls and then send data back as soon as those call results are done. And so there's limited sort of lag time there. We're looking at some other use cases that are less dependent on a call center. That might be, a call between a pharmacy and another pharmacy, or a call between a pharmacy and a patient to set up sort of prescription refill shipments. Those are areas where, the system could run 24/7 because there aren't limitations on those hours. But when it comes to calling payers, we are, tied to their call center hours of operation.
Mm-hmm. Okay. And does it post back into your host system?
It does. And so the goal is, what we want to do is not only automate the call, but automate what happens before and after the call. So for example, how does your team know when to make a call? Is that something that gets set up in a work queue? Is that some analysis based on information that somebody is reading and assessing? We want to mimic what that is so that we know whenever a patient is at the right point in your workflow where one of these calls has to happen, that can get sent to us. We make the call, we get the data, and then the analysis we do with our customers is, well, what do you do with the data that you get from the calls? Where does it go? Does it go into discrete fields? Does it go into a PDF that gets appended to the record? Does it go to somewhere else? And so we're working through all of those kinds of unique sort of outputs and inputs from our customers. Related to that, I think the question in the chat about EMR, we've begun our first Epic integration. We're also working with a health system in the southern part of the US, I'll say, on a Cerner and Theragy integration. So their pharmacy operations team is figuring out how we can pilot with them. And we're trying to figure out from a data perspective, does that data come out of Cerner? Does it come out of Theragy? And then whichever that sort of system of record is, that's what we'll integrate to. So we've begun our journey around Epic, and we'll continue to wrap that up, we think, by the March timeframe for our first Epic integration. But that's something that we can then share with others. That this is how we've done it with Epic. This is how you can view the data. And this is sort of what we think is going to be necessary in terms of any customization that's going to be specific to each hospital system's instance of Epic.
Okay, yeah, I'm on Cerner, so.
Yeah, which EMR systems do you work with? Can you use, you're working with on the Epic thing right now. How about, what ones, can you list those again for us?
Yeah, so Epic, we're building that out now. Cerner,
Okay.
we're going to be building out in the next probably 3 months with that health system in the South. And those are the two we're primarily focused on. We do interface with other practice management systems, patient management systems. So there's a variety of other, as you go into the surgical centers, they use systems like surgical information system, or they might use
Okay.
ModMed or other things that we can integrate to. And those are systems where the integrations are a little easier, right, than you would expect from an Epic or a Cerner. But whatever the system is that we can get the data necessary to make the calls. So patient demographics, their insurance information, and then
Sure.
whatever codes you want us to call, whatever questions you want us to ask. And the questions don't have to be in your system, but we'll build the system out to call for you. That's the system we integrate with, and then determine sort of what's the ability to push data back. So as this group probably knows, pushing data back into Epic is a challenging thing, right? And so how do you create a view of the data within your Epic workflow so they can say, okay, here's all the data that has been captured about this patient. I can tie it to the patient record, and then I can move into whatever the next step is in my workflow with that patient.
How about Margarita, I think that's how you say your name, Osorio had a question. And I will, if you want to unmute.
Hi, Julie. Yes.
Hi.
My question was actually answered. I was going to ask Brian if it was any experience with Cerner integrating this system, but it was answered. Thank you.
Okay, you bet. Thank you. Well, you see a lot of people are interested here.
The one point I'll raise, I didn't talk about, it's listed on the slide, is one of the things we do with all of our customers is we typically do a pilot or proof of concept that doesn't require integration. So again, to sort of prove out the ROI, where we can take basically a spreadsheet of the calls you want us to make. We make the calls, we'll create a dashboard that shows you all of the call results, the call recordings, as well as give you a spreadsheet of data back. Most of our customers like that process because it's, again, a low code way of kind of showing the value of the technology without having to go through integration. And it's also a very quick sort of time frame. So by the time we get sort of approvals from folks, because again, as we're dealing with PHI, we have to go through all the security reviews that you would expect, and we would expect to go through that. But to do a pilot for any customer to configure the platform for your particular question set, especially if it's a payer-facing call request, we can do in a couple of weeks. And we typically do a pilot with 100, 200 patients, and we can go through those 100, 200 patients, share data, collaborate with you in any sort of modifications or tweaks we might need along the way, and have that sort of completed, pilot process done in 30 to 45 days. So that at the end of that, you're seeing the results and say, yes, Eva's able to complete these calls. The data quality is what I would expect to be. And then it gives you the ammunition to then say, okay, if I want to go and use this system ongoing, the system itself, Eva's ready to go for you. And now it's a question of, okay, what integrations do we need to do to make this the most efficient as possible? And again, it gives you then some coverage and some metrics to be able to show to your IT staff, to your finance staff, that this is a worthwhile investment to make if you're going down an integration route.
Oh, thank you. There's a question from Gentry, and when there are long holds with payers, how does Eva handle that? Does Eva just stay on hold until the call is answered? Or is there a time period out?
She does. So we don't have a time stamp that says, okay, in 2 hours we're gonna sort of kick off, and we're completing about 120,000 re-verification calls in January. And as you would expect, and maybe as you or your teams are experiencing, hold times are brutal. And so, Eva can hang out as long as she needs to hang out. During normal non sort of January re-verification time, Eva's also going to learn, okay, when I call the payer, my average hold time for this particular period of time, could it be a week, could be a month, is, let's say it's 35 minutes. And if we get into sort of the 50 or 60 minutes, it's often faster to call, hang up, call again, and go through the process again, because you might get a faster response or hang up time or connection time. So long-winded answer saying we can hold as long as necessary, but Eva also learns from every interaction that she does to kind of know, is there an alternative path that might be a faster way of getting a connection with a payer agent?
Any other questions or thoughts, Terry?
Well, I think Gentry put another one in there.
Okay.
Yeah, we can provide some reporting on the average hold times with the payer. We do.
Mhm. And Brian, is it able to go from like step A to step B to step C?
It is, and so it's the advancements in the language model are more than sort of a decision tree that says if this then this, right? So the system Eva can, today we handle probably some of the most complex kinds of benefit requests, especially on the benefit side, because that's typically where the longer is. And so if we find out there's it's a PPO plan, you're not going to ask for a referral, or if we find out there's a buy and bill option, we'll also ask, well, is specialty pharmacy available, and what's the pharmacy that's available for this particular medication? What we do is we'll sort of map out all of the possible answers that our customers are looking to get from a particular call, but we kind of know how to structure those questions in a way that then gets to whatever the root cause is. And then we also have calls where we might be calling, I think about a patient access program we support where we call.
I'm gonna go get Possibly. Come and take the picture, you guys. Ready?
Go ahead, take the picture. I can't put her on mute. No, the sort of the nuance of we call a major medical plan for a particular medication, and if the patient has any form of out-of-pocket for that medication or the major medical, the business rules from our customers don't now call the pharmacy and find out if the patient has an out-of-pocket there as well, so we can present both back to the patient and give them the best possible angle. So that's on a one-off basis in terms of what we find out on a particular patient in a particular plan. So it is sophisticated enough to be able to not only go where we need to go, but as it learns from the calls that it makes. So if it makes let's say 100 calls to a particular plan about a certain treatment or a certain medication, it will know kind of what to expect in terms of things like prior auth requirements. And then if a payer agent ever says, well, prior auth's not required for this medication, but Eva's called that plan 100 times and 100% of the time or 90% of the time, they say, yes, it is required. Eva can actually push back and say, hey, would you mind checking that again? I normally hear prior auth is required. And then the human agent will typically go back and say, oh, you're right, I was looking at last year's documents. I mean, it's a hard job on the payer side. They have to navigate and look at multiple systems. They have to look at PDFs to check on policy requirements. And all of those sort of back and forth do, create sort of human error on the payer side. But that payer intelligence layer can help not only ensure we're capturing the right data that we hear, but also getting the correct benefits when something just seems out of the normal from what Eva has experienced before.
I just wanted to, some of the things I'd like to bring in that I think maybe the group is interested in, not just your, Eva, but just some of the new things out there in the patient access world. So is there more to your story here?
Well, so what we're doing is we're the engine for a lot of patient access programs out there. I mean, that's where we started our business, and probably 10 of the largest patient access programs are customers of ours. So we're giving those businesses great efficiencies to be able to do that. And now, because we are integrated into their systems, that gives us a chance to say, okay, what if we could, based on a certain code that we're being asked to check on for a provider's office or a health system, also then take that information and bring that to the patient access program. That gives us another linkage into the world. So they're also looking for efficiencies. They're also going through the same staffing challenges that everyone in healthcare is going through, and are looking for ways to help offset that staffing challenge with a technology that can give them the quality that they're looking for in terms of data, but can also go through the kind of lengthy phone calls that this kind of process requires. Versus there are lots of technologies, AI bots that are out there that you and I might experience on a website, where we can ask a question, we might get a response or two before the system sort of reaches its end. Versus we have calls where we might be having a 35-minute conversation with a payer agent to capture all the data points that our customers are looking for.
There's another question in the chat here. What happens to calls that Eva is not able to complete? What is the turnaround time? Would we be notified there was an error with that requested call? You
would get instant notification of the error, and I'll give you a couple of examples of when we're not able to complete. So one example is we're engaged with the payer, and there's a unexpected disconnect from the payer. So we weren't able to complete that call. What typically happens is we requeue that call, reach out to the payer again immediately. Once we get through the IVR and hold and we speak to the person, then we pick up wherever we left off with the question set that we need to then return the complete call information to the customer. Another example of when you not complete a call is maybe we've received a member ID that's incorrect, or that member's no longer a member for a particular plan. We'll ask the payer to try to locate the patient with their name, date of birth. But if they say, I'm sorry, this patient's not in the system, we'll return that to our customers as an incomplete call with the reason that, patient not found or patient not part of the plan. So the reason for the unable to be completed is a data point that we provide back. But in the case when it's a technological cutoff for some reason, it's simply, and all of our customers sort of use this process today, we just requeue it in order to complete whatever data we need to get from that payer.
So it automatically does it?
It automatically does it, correct.
So I assume there's like a work list or an exception list when you have a failure like that?
When you say a work list, what are you, just so I'm following your definition of that.
Okay, so we have a list of patients coming in. So I'm thinking about this for our pre-registration team.
Okay.
So we have staff in front of our pre-registration. So the appointment is scheduled. Somebody has possibly requested an authorization, and they most likely have, a copay or share of cost or something with it. And they don't have, if I'm not even sure, because I got in the middle of this, right? If you have to do it for each list, or it's for each call, or you put the calls on a list to do it, how does that happen? That's what I'm missing.
Got it. Thank you for that clarification. So some of our customers send us the call requests in a batch form, like certain parts of the day. Some customers, so in your scenario, as you have a patient that's going through the pre-registration process, and the next step in your workflow is to make a call to get some information, that can be sent to us to then make the call and then send the data back. And so as you have patients that go to that specific point in the workflow where a call is necessary, we can set up our processes to just take that call request and then move forward. So you don't have to think about, is this something I should send to Infinitus or send to Eva or not? It can be set up in an automated way if we like, or we have had a health system ask, could it be where, based on analysis from the registration staff, they could either choose to make the call, or there's some sort of button that says send to Eva. I think we could create something along those lines as well. So it's either automated through your workflow, so as your patient gets to the point where a call is necessary, or you could send us calls in a sort of a more manual fashion that's sort of batched up. It's entirely up to you and what would be more convenient for you.
Can you take one of our work lists and ping it from there to begin the process?
That's what we're looking at from the Epic integration we're doing now, is actually adding Eva to that work list and that queue. So instead of it going to a team or a person that it goes to today, the next selection with that would be to Eva. So that is an option we could do.
Yeah, that's intriguing. Yeah, because in order to get full, I'm thinking about really full automation, sort of hands off, except for the unsuccessful or the exceptions, so to speak. Yeah.
Right. And so you could give us business rules to say, here are the exceptions where it doesn't make sense to send this to Eva. And then we would set up through the integration that if a patient is at that next point in that workflow or work queue, does it have any of these exception criteria? If not, it gets sent to Eva. If it does, then it doesn't get sent. So we're not making calls that we shouldn't be making, or calls where, based on exception rules that you set up, you would prefer your team to make for a variety of reasons.
Okay. Thank you.
Welcome.
Mm-hmm. Any other questions?
So Matt and I are available for parties. Happy to have this conversation with your individual, practices, groups, systems. as
Sure.
further conversation. So, just say we're very appreciative of the time, and, we welcome any further sort of conversation and insight. And so, one of the things we can send Julie is, these slides and that demo, if that's a helpful thing to send, or we can just direct folks to our website.
And we're actually recording this too, by the way.
Nice, good. Yeah, but I definitely think if we can take a peek at that demo that you did, I think that would be really fabulous. Brian, are you guys going to be at HFMA next week?
I am not, due to a conflict of schedule, and I don't know that we are. Maybe we should.
You should be.
You should be there. You should be. Yeah, Brian, you should be there for sure.
Okay. Well,
Yeah. It might be a little late for that because you won't be able to get a booth at this point. But, the other thing is I would love for you to exhibit at CAHAM. I mean, I think I have both the front and the back side. So this is, there's possibilities for both. And it's super intriguing. It definitely, you need to consider exhibiting at CAHAM, become a partner with us.
Yes.
We would love to learn more about that, and I think that's a great idea. So Matt and I can take that as a follow-up to, whether we work directly with you or just go to the website and figure out sort of KM and how we do that. That makes a lot of sense.
Yeah, I need an email, so that's really all I need probably from you. So I can get that, after the chat too.
Fantastic.
Okay.
Well, we've got some good things on the horizon with our webinars. Does anyone else have any other questions or thoughts? Okay.
Well, I'd like to give a little plug for our upcoming conference.
Absolutely.
And Julie, thank you this is a super valuable demonstration and really looking towards, the future of artificial intelligence. I'm loving this. So we will, for everybody else that's on the call, we will be having our 54th annual CAHAM conference this year in September. It's the 24th through the 26th. So that's a Sunday through Wednesday. And it's going to be in Paso Robles at the Allegretto Vineyard. And happy to send you information to that, or you can write to CAHAM through the website. There's a link on there and get information, or just have yourselves added to our database and we can send you some information on that. But so that's for providers, but definitely for Brian, definitely we need to connect.
And I will get you two connected.
Thank you, Julie. Thank you.
You bet. Well, I appreciate everyone's time. I know it's valuable, and I will give you back 20 minutes in your day.
Great.